First and foremost, I would like to congratulate Dr. Khanna and team for having such an excellent conference on this subject, very well needed. Now, today I'm going to talk on metabolic acidosis. Am I audible?
Yes, sir.
Very clearly, sir. Very clearly.
Yes. Okay, fine. So basically, this topic I am going to have some of the brief outline, and first we will start with the basic understanding that what metabolic acidosis is. See, when we talk about metabolic acidosis, the first question that what acidosis and what pH is. Now the pH is determined by two things. Number one, it is bicarbonate, and second is PCO2. So when bicarbonate is normal 24, PCO2 is normal 40, then pH will be 7.4. So this is how it is actually calculated. When pH is less than 7.35, it is acidosis, and when pH is greater than 7.45, then it is alkalosis. Now the question arises that what are the primary disorders? Because metabolic acidosis is one out of that. So primary change in bicarbonate leads to metabolic acidosis and metabolic alkalosis. Primary change in PCO2 leads to respiratory acidosis and respiratory alkalosis. But today we are going to talk only on metabolic acidosis, where primary change is low bicarbonate, which gives rise to low pH, and secondary change will be PCO2. So it's a balance that when bicarbonate is low, pH will reduce, and that's how metabolic acidosis will be characterized by acidosis that is low pH and low bicarbonate. But we need to keep in mind that low bicarbonate can be as a primary change because of metabolic acidosis, and even in respiratory alkalosis, when PCO2 reduces, the compensatory change will be reduction in bicarbonate, and therefore bicarb can reduce because of two reasons. So if the bicarb is low with low pH, our diagnosis is metabolic acidosis. If bicarb is low but pH is high, our diagnosis is respiratory alkalosis. So it is either because of bicarb loss or because of the acid is added, or kidney is unable to excrete bicarbonate. Now, when we look at the metabolic acidosis, always check anion gap. Anion gap is sodium minus total of chloride plus bicarbonate, and its normal value is 12 plus or minus 2. If anion gap is high, we can say that yes, metabolic acidosis is of high anion gap. So on basis of anion gap, metabolic acidosis is divided into two parts: normal anion gap and high anion gap. The cause of normal anion gap metabolic acidosis is like severe diarrhea, renal tubular acidosis. High anion gap is like ketoacidosis, lactic acidosis, and renal failure and others. Now, when we talk about etiology, basically either there is increased acid excretion, or bicarbonate is lost, or there is diminished renal acid excretion. So these are some of the important causes which we have summarized here. We will not go in depth of everyone. Now, what are the symptoms of metabolic acidosis? The symptoms of patient varies. First, that it may be manifestation of underlying disease like patient with diarrhea, decay, shock, patient CKD. There will be symptoms of associated problem. Basic symptoms of metabolic acidosis, which we will cover just now, and sometimes patient may be asymptomatic and it is accidentally diagnosed. Now, when we talk about symptoms of metabolic acidosis, respiratory symptoms as a compensation, that is hyperventilation or Kussmaul's breathing, is something which is common, and that tells us that yes, there is underlying metabolic acidosis. Because of metabolic acidosis, it can lead to cardiovascular effects like tachycardia, susceptibility to develop cardiac arrhythmia. They are more prone to develop hypotension, and if they are hypotensive, acidosis is present, there is decreased response to inotropes. Neurological problem like headache, confusion, lethargy can occur, and there is possibility that because of metabolic acidosis, these patients are more prone to develop hyperkalemia. So if patient is metabolic acidosis, we need to keep in mind that hyperkalemia is a possible thing. Now, coming to how do we manage metabolic acidosis, it's a broad topic, but very, very important to remember that look at the underlying disorder, and treatment of underlying problem is the most important measure to manage metabolic acidosis. And we need to provide bicarb, we need to provide, we directly need to treat metabolic acidosis in some of the patient. But if patient is having mild to moderate acidosis, treatment of underlying problem may be enough. Alkali therapy should be reserved for selective patient with severe acidosis. The treatment of all acidosis with sodium bicarbonate is not only unnecessary, but it can also be detrimental. Now, the question arises that why we should treat patient with metabolic acidosis. Answer is that it's because of its detrimental side effect like Kussmaul's breathing, risk of arrhythmia, myocardial depression causing hypotension, impaired response to vasopressors, and possible risk of the hyperkalemia. Now, if it is so much useful, why we should be cautious and why we are concerned about using bicarbonate judiciously? Because it has many side effects. It's rich in sodium, so can cause hypernatremia, volume overload, CNS acidosis, hypokalemia, hypocalcemia, overshoot or rebound alkalosis in patient with organic acidosis. And because of this reason, it's very important that we should use this molecule, sodium bicarbonate, meticulously. Important to remember that 100 ml of bicarb, which we are using, contains 90 milliequivalent of sodium, and therefore amongst all available agents as compared to 3% NaCl or others, it has almost, as compared to 3% NaCl, it has a almost double concentration of sodium, and therefore they are at risk of developing hypernatremia and volume overload, should be used cautiously. Now, when to treat metabolic acidosis? See, there are many indications, and its use depends upon for what problem are we using bicarb therapy. In patient with high NI and gap metabolic acidosis, the basic principle is that not recommended routinely. Use judiciously, and whenever you are using it, use it only for partial collection. Our aim should not be that we bring a pH to 7.4 or we try to bring bicarbonate to 24. No. In such case, bicarbonate therapy can be harmful. Mild to moderate acidosis may be beneficial in high NI and gap metabolic acidosis, and therefore try to provide only when it is pH is low, and try to bring pH to little greater than 7.2 and then leave it as it is. So this is what is important. See, lactic acidosis, which is common, it's high NI and gap metabolic acidosis. So use of bicarbonate is controversial, but should be given when it is severe, life-threatening, pH is less than 7.1. Start with late, discontinue early, discontinue when pH is greater than 7.2. Now, normal NI and gap metabolic acidosis, like patient with diarrhea, indicated early and should be discontinued late. Should be started even with little lower pH or even bicarbonate is less than 16 to 80. Replacement of bicarbonate is very important. It's beneficial and hastens the recovery. In diabetic ketoacidosis, when we talk about, it's rarely used and usually avoided. And in diabetic ketoacidosis, the role of bicarbonate therapy is only when it is extremely severe, like pH less than 6.9. Otherwise, it is not required. In patient with metabolic acidosis and hyperkalemia, along with my learned friend, Dr. Raju has already narrated all aspects of hyperkalemia. but bicarbonate therapy shifts potassium intracellularly and corrects hyperkalemia, and therefore in acute management of the hyperkalemia, if patient is acidotic, correction of the bicarbonate with bicarbonate, with sodium bicarbonate may be helpful. Now, if patient is having hypokalemia, then it's very important that, see, we have two problems. One is acidosis and second is hypokalemia. So if hypokalemia is severe, correct hypokalemia before correcting acidosis. See, if acidosis is corrected, that is going to aggravate hypokalemia, and in severe hypokalemia, it may precipitate respiratory failure, and therefore it's very, very important that when you are treating metabolic acidosis, look at the potassium. If it is hypokalemia, treat potassium first, bring it to little comfortable safe zone, more than 3.5, and then continue potassium supplementation and simultaneously treat metabolic acidosis. This is something which is important. Now, coming to the last part, and the most important for all of us is CKD. Now, say in chronic kidney disease, especially when it is of chronic tubulointerstitial disease, metabolic acidosis is very common, and this metabolic acidosis is going to be harmful. Different ways by which it can cause the harm is it increases the risk of CKD progression. It leads to bone demineralization, so weakens the bone, and even the muscular weakness is going to be, skeletal weakness is going to be very, very important, and that increases the risk of even death when pH is less. Even high pH is going to be harmful, and therefore try to keep bicarbonate level between 24 to 26, which is the ideal as per the current recommendation. It's very important that metabolic acidosis is one of the important risk factor for CKD progression, and the correction of metabolic acidosis in CKD can slow down the CKD progression. In some of the patients with severe acidosis, when we start bicarbonate therapy, all of us have observed that creatinine, which is higher, will come down to little lower level, and we can settle it down in lower value of serum creatinine, and it improves outcome. It decreases the overall weakness, skeletal weakness, and because of all this reason, it is very important that metabolic acidosis should be looked for in every patient of chronic kidney disease, and should be meticulously treated with oral bicarb therapy, which is easily available, and with the aim to bring pH, bring bicarbonate between 24 to 26. So this is something which is very important. I think it is a short time to discuss metabolic acidosis. So with this, I would like to end, and would like to thank all of you for supporting this fluid therapy book and supporting our kidney education mission, where book is available in 39 languages. This is received World Record Award. It's available in 27 international languages and 12 Indian languages. So it's a popular book, and it's because of the efforts of more than 100 nephrologists across the world. We are supported and blessed by many and all. Thank you very much.